Hi, friends, and welcome to Let's Talk About Healthcare, a podcast about the challenges and the opportunities, the good and the not so good, and the moments of joy found all across our healthcare system today. And remember, it's up to all of us to make healthcare work better for everyone, one day at a time. Hello, friends, and welcome to the next episode of Let's Talk About Healthcare with Provider Trust. I'm your host, Dave, and we have an incredible session and guest planned for you today. Just really excited to share. Without further ado, we'll get right into it. Today's guest on this episode is Lauren Haley. Lauren is currently an attorney at Strategic Health Law, but has an amazing background, just everything from working with payers to policy to directly with CMS, and certainly on the legal side as well. Beyond just her experience at Strategic Health Law, she was formerly the Vice President of Pharmacy and Medicare Compliance at Magellan Health, as well as an Associate General Counsel. She's worked for legal startups from a compliance perspective. She's been a partner in McDermott, Will & Emery, and certainly earlier in her career even worked directly with CMS. And I know some of that experience will influence some of our conversation today. So we're so thrilled to be able to partner with and have Lauren join us today. Lauren, welcome to the podcast.
Well, thanks so much, Dave. I should let you continue and talk about me.
Well, along those lines, I'm sure the introduction I just gave was a rather poor one. So I'd love for you to just tell our listeners a little bit about you, your background, and sort of kind of where you started your career. How did you end up where you are today?
So I actually have been in healthcare policy since college, believe it or not. My undergrad degree was in health and society from Rochester, and part of my studies was, I actually looked at ICD-9 and CPT codes. I learned that at a very early age. Between college and law school, I worked at Memorial Sloan Kettering in Manhattan, so learned about how healthcare is delivered and got that experience. And then I left there to go to law school. I went to Seton Hall Law School, where I was able to concentrate in health law. So I've always been laser focused in this industry. And from graduating from Seton Hall, I've run the gamut when it comes to what I've done in healthcare law and policy. I moved to DC, believe it or not, on a wing and a prayer in 2002, which was not nearly as bad as 2000 and 2008, 2007 and 8, when there was that recession. But in 2002, it was very similar. It was right after September 11th, and people were having job offers rescinded. And I moved down there and got a job at a trade association. And I was doing government relations, and that's where I really learned about Medicare and reading manuals and understanding rulemaking. And I worked at the National Association for the Support of Long-Term Care for 2 years, and then had the opportunity to go to CMS shortly after the Medicare Modernization Act had been passed and CMS was implementing the Medicare Part D benefit. And so I spent a couple of years there. I helped work on the regulations for compliance programs for Medicare Part D plans. I helped draft the guidance related to that, which at the time is Chapter 9. It's now been expanded to 9 and 21 in the Medicare Managed Care Manual. And so I spent some time there, really learned about the regulatory process, how sausage is made, who has input, really saw how the Administrative Act plays out with notice and comment, rulemaking comments. So that all worked out. I left CMS and ended up going into private practice, and that's where I worked at Big Law. I was at Mintz Levin for 4 years, and then I was at McDermott, Will & Emery, and represented payers and vendors to payers, PBMs and similar types of entities, and help them at the time, initially focus on Medicare Part D and implement those products. It was so early in the program. There were lots and lots of questions about that. And then it also expanded because there was such an overlap to Medicare Advantage, and worked in that space. And then I had an opportunity to move with my family to Newport, Rhode Island, where I worked at a startup for a company that was kind of like a small PBM. They negotiated rebates, carve-out rebates. And so I did that for a couple of years. It was acquired by a big corporation. So then I went to a big corporation. I was there for several years and helped them stand up a Part D plan. And then I left, and I've been with Strategic Health Law now for about 4.5 years, which is this small little boutique firm. And we represent payers primarily in the government funded space. So Medicare Advantage, Medicare Part D, and Medicaid managed care. We dabble a little bit with exchange plans, but mostly we're government funded.
So first of all, it's you've had such a remarkable journey and career from CMS to legal to payer to just everything in between to the startup world. Even what's been the common thread for you? What has been your passion through and through that helps you navigate all these different career stops, and what's been such a remarkable story?
So healthcare is so complex, and I am jazzed by it. I think as a culture, we struggle with whether healthcare is a privilege or a right. And I think that drives a lot of this, the struggle that we have. There's how it's regulated, from licensing to credentialing to reimbursement to compliance. It's how it's financed from the government, from employers, from private pay. I think marketing plays has a factor in this because of direct consumer marketing. And take drugs, for example. Now that everyone needs whatever is being advertised, right? But no one really realizes how much that costs. There's the influence, I think, on malpractice and liability, which drives up, not only cost, but also drives up utilization because providers are so nervous about exposing themselves to liability if they miss something. So there are all of these pieces that somehow fit into the puzzle, and they're all interrelated on some level. And if you pull one, the other one kind of shifts up. And so in each of my roles, I've been impacted by some level of that puzzle. And that's what I think the thread is, and what keeps me motivated and engaged, candidly, because just as I think I seem to understand one side of things, another side will pop up and say, well, what about this? And then you need to sort of untangle it as best you can. So that, I would say, probably is the common thread.
In looking at that puzzle, and how that, I'm just curious from your perspective, given your so many different vantage points, how has that puzzle changed, right? In your world over, the past few years or past few presidential administrations, right? What have you seen from your seat that you're like, this is the ways the puzzle has changed or hasn't changed?
I don't know if it changes. I mean, I think that there are common themes that have not gone away. So this concept of managed care seems to go in and out. The concept of managed care has been around since the 80s. And whether or not it's utilized or accepted or understood flows in and out. Value-based purchasing, value-based care. In the early 2000s, pay for performance was like the hot topic. And isn't what we're talking about now just another flavor of that, or another iteration of that? I think that it ebbs and flows with respect to oversight and enforcement and regulation as compared to letting market forces, control what's happened. When I think back about Medicare Part D, and when that was getting ready to launch, there was a lot of concern that there wouldn't be interest from the market. And so some of the policies at the time were designed to encourage market participation. And then several years later, the administration changed. They realized they had too many participants. And so then they tightened some of the regulations. So I think we see some of those, I would say, ebbs and flows. I don't know if it's really changes. I think it's ebbs and flows over time, over years. So I think that would probably be the biggest.
Yeah, that's fascinating. I think, so much of what I know we wanted to talk to you with about today is the change in regulation from administration to administration. And so I think just to just to ground us a little bit, is what, from your perspective, what are the standard expectations for healthcare regulation during an administration and during an administrative transition from president to president?
Right. Well, I think it's president to president and party to party. When you change, if the party is staying the same, the policy and the politics typically stay the same, and you will generally keep the leadership, right? You'll keep the secretary and you'll keep the administrator, or at least those individuals, if they choose to move on, have a say in who their successor is going to be. When you change administration, all of that changes, and we're sort of in the middle of that now, right? Like Becerra was just confirmed late in March, I think it was, and then we're still waiting for Brooks LaSure for her confirmation. And so when you have those shift, there's a period of time when there's uncertainty because you're not sure what's going to happen. But I think generally speaking, you'll see some of the focus change. I think if you have a Republican administration, you will generally see more regulations that tend to encourage market competition. You will tend to see a little bit more hands-off. I know with the Trump administration, we saw fewer penalties, at least for MA and Part D plans. The CMPs, civil monetary penalties coming out of audits, were a little bit lower than what we had seen in the past. So you might see that with our Democrat administration, you might see focus on expansion, right? More regulation, more expansion, more oversight, more enforcement. So I think, that's very high level, and there are lots of exceptions to the rule, but generally speaking, that's what I think we can expect. But because it's taking quite a while right now for the various individuals to get confirmed, it feels to a degree like we're in a holding pattern.
Yeah, and what from what did we see, or what did you see, right, from the work that you've been doing over the last couple of years? What specific trends? You mentioned a few, just CMPs being down a little bit, some of the enforcement trends being down a little bit under the Trump administration. But what anything else that comes to mind that you noticed or you observed during the Trump administration specifically?
Well, so interestingly, one of the things we saw was the explosion with some of the models that CMS came out with through the Innovation Center and CMMI. I mean, it was almost like a headspin to try and keep track of all of the potential models that came out. And since Biden has taken office, CMS has put a hold on some of them to say, let's hold back a little bit and look at what all of these models are, because it was confusing to the industry to see what was out there. There seemed to be a lot of similarities, a lot of overlap between them. But we did see, anyway, in the Trump administration, explosion with these models to try and come up with new and innovative ways to deliver healthcare. To really, the quality and access is everybody's marching to that same drumbeat: quality and access. So the Republican administration was, can we do this through competitive models somehow? And that was through CMMI. So there was this explosion of that in Trump administration. Then we also saw them relax certain regulatory requirements to give more flexibility, especially to health plans and Part D plans. One great example of that would be they rescinded the requirement for meaningful differences between plans. It used to be that MA plans could only offer plans that had meaningful differences within a certain service area, so as to reduce confusion. And then ultimately the administration backed off on that, arguing basically that the market would determine whether or not you had too many choices.
Yeah, that's fascinating. And so as we look forward to the Biden administration then, and you mentioned both of them already, but Xavier Barrera, Chiquita Brooks-LaSure, what do we know about them? What can we expect from them? What are you anticipating? I know they haven't, the confirmations necessarily aren't signed, sealed, delivered yet, but looking forward, what would we anticipate?
I think that they are a really interesting duo and complement each other in some remarkable ways. So Becerra is an attorney. is known as an aggressive enforcement agent. He was the Attorney General for California. He was a supporter or protector of the Affordable Care Act. His policy goal is to expand access. He has an interest in women's health. So I think, we'll see the access, we'll see the expansion in access, but I also think his background as an attorney and as a litigator will impact the enforcement, what we'll see from enforcement, at least going forward. I think we can expect that. Brooks LaSure, she has a strong background in healthcare policy. She worked on the Hill. She was a Medicaid analyst at OMB. She worked on House Ways and Means Committee. So she oversaw the implementation of the ACA as the Deputy Director of the Consumer Information Insurance Oversight Center at CMS. And so, she has a lot of background in healthcare policy. And so I think between the two of them, with the enforcement background and focus from Becerra and the policy experience and focus from Brooks LaSure, they present a really, I think, well-rounded duo for going forward. Now, the interesting thing, they both have, their focus is states, right? Becerra was the AG for California, and Brooks LaSure, her focus really was on the ACA plans and Medicaid policy. It'll be interesting to see how that trickles down, their policies trickle down into Medicare oversight, which is truly a federal program, versus, the ACA plans and the Medicaid plans. But even still, I think their focus on, the legal side, the enforcement side, and the policy side presents a pretty well-rounded duo.
And for the folks listening, that when you say trickle down into Medicare, what does that mean from your perspective for folks that may not be as close to it? So what are you referring to specifically?
Medicare is a federal program. It is not, for some providers, it's a little bit regionalized because of how the regions are set up. But generally speaking, it's a national program. How, what the policies are a national program. The payment rates are a national rate, versus the ACA plans, which are state plans, state insured plans, and the Medicaid policies are state policies, whether it's fee for service or if it's Medicaid managed care. So it's really localized. And so when you have two individuals whose perspective might arguably be state perspectives versus a federal perspective for Medicare, what is unclear to me is how whether or not there will be a shift in any kind of focus to, how there will be an interplay between the state focus of the ACA plans and Medicaid versus the federal program of Medicare.
Got it. That makes a lot of sense. And so as we talked specifics, right, of Trump, the Trump administration, the Biden administration, and then now going a little bit broader, right, is I just want to ask, loosely on the macroeconomic trends that you see, and to read the tea leaves or gaze into the crystal ball a little bit and look forward. And, for each of sort of some of the big topics that you tend to run into, what are you anticipating looking forward? And so the first one would be like oversight and audits. What does that look like moving forward? Some of the things that I know we're interested in is the world of telehealth. Value-based care, you've already mentioned, and some of the things that we would anticipate that. Again, it seems to ebb and flow a little bit, to use your words as well, and just overall enforcement trends moving forward. I know you've touched on that a little bit, but when you think those pieces to the puzzle, looking forward a little bit, what are you anticipating given your seat?
So I think that oversight and audits will absolutely continue. I would not be shocked if there's an increase in CMPs, if CMS holds plans in particular, and probably providers a little, their feet a little closer to the fire, and really holds them accountable for meeting various requirements. And that's not to say that plans and providers aren't always trying to meet requirements, right? Like, it's almost an impossible task because they're always changing and they're so complicated, and CMS is governing from this micro level or macro level. It's really challenging. So I don't mean to suggest that anyone's not trying their very best. It's just whether or not there will be penalties that are associated, or higher penalties associated with not complying. I also think there's a lot of uncertainty with respect to risk adjustment and RADV audits, and how that will look, and whether or not CMS will actually start extrapolating. So I anticipate there to be a lot of activity in oversight and audits, especially with this change in administration as they start catching their stride. With respect to telehealth, I think that will absolutely, we saw an explosion in 2020 as a result of the virus. Becerra has expressed his support for further expansion of telehealth. I think that toothpaste is out. I mean, we are going to start now working with telehealth. I think that there are probably a lot of questions. We're going to have to now catch up with all of the structure, right, that normally is put into place before you release something like that. We released it before anyone was really ready or thought about it. And so now we're going to be trying to build a structure around it. I think there'll probably be some audits, around telehealth and the use of telehealth. I think there are questions about going back to risk adjustment. The agency has said that you can use telehealth as long as there's a face-to-face video for risk adjustment purposes. However, they said you can't just use telephones. I think that there's something right now on the Hill being considered. So, that's something that we can look at as well.
I was going to ask about telehealth. Has any of that actually hit your world yet, right? Has that started some of the look back and setting up the infrastructure, the regulatory environment? Like, how much of that is happening yet, or how much of that hasn't, and we're waiting for it?
From my perspective, I think we're still waiting for it. I think that payers and providers have been using the technology. I think I know we've seen the growth. CMS has been regulating through memos by necessity, like totally understand why. However, at the end of the day, they will need to transition a lot of this into regulation, and it just hasn't been released yet. So I anticipate it. I anticipate more formal processes to be released by CMS. But candidly, I don't know when that will be.
Sure. Makes a lot of sense. As we wanted to pull us back for a second and ask, as I've asked you to do a lot of looking forward, but if you're going to look back, what are some of the things in your brilliant career that you're most proud of, right? You've been involved in so much from a policy perspective, from a startup perspective, from a legal perspective. What are the things that you look back on and really just bring you joy?
Bring me joy. I would say working at CMS when Part D went live was really such an amazing experience. I worked with some really bright and driven people. We were creating this whole program. I mean, the MMA is a big piece of legislation, but there was a lot to create and figure out along the way, and collaborate with industry and, draft things. And sometimes you got it wrong and sometimes you got it right. Chapter 9 of the Prescription Drug Benefit Manual ended up exploding, and it's created, so much opportunity for so many people. And so that has been, I would say, the thing that I'm most proud of.
Very cool. Very cool. As we sort of move to wrap up a little bit, what excites you the most about the future of healthcare? Again, going back to looking forward, is what is most exciting?
Well, I think it's going to continue to be complex, and the complexity will only increase as technology explodes. I think that we will see more innovation and more innovative arrangements around particularly value-based care. The OIG released a few new safe harbors to the kickback statute at the end of 2020. And so that creates some new opportunities that I think the industry hasn't even really wrapped their heads around yet. But as they begin to really consider those, I think that there will be some new arrangements that candidly will improve quality and care and access, which is ultimately what everyone I like to think is driving towards.
Yeah, absolutely. I have two questions for you before we wrap up. The first one is, if you could wave a magic wand and change one thing about healthcare, what would that thing be?
It's actually a fundamental thing. I wish we could agree as a culture how to view healthcare. Because I think if we could agree as a culture how to view healthcare, we could then draft the policies around it. So do we think it's a right? Do we think it's a privilege? Do we think it's something in between? I had read an article many years ago that argued that we should equate healthcare to education, where you have some level, basically of some ground level that is public, and then you have, if people want more, they buy more, which I think is an interesting way to approach it. I think it's tough because there's always going to be a gray area. But I thought it was an interesting way to approach it.
Where is it too much to ask to say, where do you fall in that debate? How do you view healthcare?
I truly think it's something in between. I think that there are some really easy things to say. Everyone should have access to a PCP and should be able to get antibiotics when they have strep throat. Mm-hmm. And an appendectomy should be, the cost of an appendectomy should be what it is, regardless of who's paying. And if you walk in off the street, we've all read those articles of how self-pay patients get screwed, for lack of a better term, or maybe that is a legal term. If they can't afford it, their rate is one time like $19,000 or $20,000 versus what a payer would pay for, $5. So, I think things like that, versus someone who is going in for plastic surgery for truly cosmetic reasons, right? Like nobody wants to pay for that. So, I think that those are the obvious ones, but if you start drawing more in the middle, so if you have 4 different drugs that treat a disease, does everyone really need to get the most expensive one? And to what degree can you sort of say, well, I think that this other, and I guess, that's a cop-out example because this is why you have formularies and PBMs and all of that, but it's an easy way to think about it because not everybody needs all of the same treatments or the ones that have been candidly marketed to them.
Yeah, absolutely. Thanks for sharing. The last question before we wrap is, what are you reading? What's gotten you excited lately? What are you learning about? I'm fascinated to hear, whether that has anything to do with healthcare or not. But what have you been reading lately?
So this will have nothing to do with healthcare. I start every year with my annual New Year's resolution is to read 2 books a month.
Okay.
I don't always meet that, but it's always my goal. And so right now I'm reading The Splendid and the Vile by Erik Larson. And I don't know if you've heard of that book, but it's about Winston Churchill's first year as Britain's prime minister in 1940.
That's awesome.
Yeah. So, and next then I have a book on Dare to Lead by Brene Brown. So
ooh, good one.
Yeah.
Very cool. Lauren, this has been amazing. Thank you for just sharing your story with us, sharing your perspective on the tea leaves, looking forward a little bit, and just for spending some time with our listeners today. We so appreciate you. This has been amazing. Just thanks again for coming on the podcast.
Of course. Thanks so much for having me. It's been fun.
Thanks for listening to this episode of Let's Talk About Healthcare. Remember, it's up to all of us to make healthcare work better for everyone, one day at a time. Catch you next time.